Hello and welcome to the Clean Film and CT webinar. My name is Seidel. I'm the Customer Success Specialist at Collective Minds. I can see that a lot of new people have joined today. So for those who haven't been here before, we normally, Dr. Imran Lasker normally go through a couple of cases, and then he asks you to look at the cases. Everyone who's joining tonight should have an account with Collective Minds, and if you don't, please let me know, and I will help you, get access to it. But once you log in, what you're going to see on the screen is the global community, which is a big community of medical imaging professionals that consists of around 11,000, 12,000 medical imaging professionals and so on, primarily to help each other to get second opinions and look at different cases and so on. So I would really recommend look at the global community. And for the cases tonight, is actually posted on the global community. So if you go here, you can see all of the cases Imran Lasker has posted. I will also send a collection link where you can find the cases a little bit easier in the chat shortly. But before I do that, I would also like to show you the AI showcase. So with Collective Minds, we have a lot of collaborations with different universities, hospitals, and also AI companies. So if you would like to try your own cases on our AI, collaborations, just simply press on the AI showcase here. While Imran going through the cases, he's going to ask you a lot of questions. So I would do recommend you guys to write in the everyone chat. So you will have two options. Either you send it to the panelists or everyone. So make sure that you choose everyone, that option. And so everyone can see your answer. At the end of the webinar, I'll send our evaluation form. So please make sure you fill that one out so we can send out the CPD certificates. And with that being said, I'm going to stop talking now, and I'm going to leave the floor over to Dr. Imran Lasker. Let's see if it's here.
So, hi everyone. I hope everyone's well. Hopefully you guys can see me. Thank you so much for turning up today. I really do appreciate it. I think genuinely this webinar that we've been doing or monthly has been going strength to strength, which is really amazing. Really do appreciate it. And I think Collective Minds in general, their support for this and enabling the entire thing to happen in the first place is just absolutely phenomenal. So obviously I'm going to go through the platform anyway as well. As we go through it, hopefully we'll be sending a link through in the next few seconds on how to use it. I'm just going to change my camera if possible. There we go. That makes things slightly better, I think. I prefer it. Okay, so for those that don't know me, my name is Dr. Lasker. I'm a consultant radiologist. You may have seen me on Twitter and YouTube and all that kind of silliness that I like to get up to. But my real passion is teaching, and Collective Minds has really enabled me to do a lot of teaching and actually use Collective Minds for my own courses to teach my registrars and teach my courses. So radiology seminars is where I do my teaching. So if you are interested in learning more from me, maybe you like what you see, maybe you like what you hear, then feel free to go check out radiologyseminars.co.uk, and we work in collaboration with Collective Minds to make that even possible in the first place. So the link is now in the chat. Thank you, Seidel, for putting that through. Hopefully you guys can all see it. I do keep track of the chat, so if any questions come up, I'm pretty good at picking them up as we go through. The way we do it is we just open each case. So I generally open a new tab and then we go and have a look. And one of the key tips I'd say is that see that little cloud in the corner, press that just to make things slightly easier. And the way I do it is, I know I've got so many new people, which is absolutely phenomenal, with varying levels of ability. So we're going to kind of work our way up, and hopefully get to some more difficult cases later. Some of you may have seen these cases or, seen similar cases, but I hope that this is really useful for you guys. So without much further ado, let's actually go through this case. So this person has given us a left thumb x-ray, and what we'll do is, so what I always do is sort of just draw around like this, really draw around the entire thing like so, and then again like this, draw all the way around like this, all the way around like this. And what you need to do as well, like if it helps you, really zoom in, like don't be ashamed to zoom in. And as you can see, this platform is really good for that. You can see you can zoom in, again, just draw around like this and like this. And you start to see that there is a bit of a discrepancy over this particular area over here. Can you see that? I just point that out for anyone that hasn't seen it. That there is a bit of an abnormality, right? It doesn't look like it connects to the rest of the terminal tuft of the bone. So what we can do here is just we can actually reset the image, reset all. You can see this is the thumb, this is the proximal phalanx, this is going to be the middle phalanx, and this is going to be the terminal, right? Or the terminal phalanx. And you can see that there is this kind of irregularity sitting over here. You can just about see that corner nail over there. So there's no overlap. So that's one of the things I'd like to say. Be really, really careful of overlap between like soft tissue or any other other structures. And I've seen this happen before, actually, where people can see that thumb, kind of that thumbnail, and because it kind of overlaps the skin area or the bone in the area, they call it a fracture and move on, but actually there's no fracture. But in this particular situation, you can see that this goes along like this, and down like this. And actually there is what looks like a fracture. That looks like a proper discrepancy within that area there. So this would be a terminal tough fracture, no doubt about it. Okay, so if there's any questions, just feel free to put those in the chat. We'll go on to the next case. Don't worry, they get more and more difficult as we go along. So let's open up with this new tab and have a look here. So, by the way, yeah, sometimes I've uploaded these cases from quite a while ago, so I have been known to forget what it is. So if you do think that you see something that I haven't seen, just let me know. Just put it in there. Yeah, just put it in there. Right, so let's have a look and see. So what I always do is, how do you describe a thumb fracture? So the way you describe a thumb fracture on that particular one is just keep it simple. I always like to keep it simple, right? So just say this is a fracture of the tip of the terminal phalanx of the thumb. And that's it, right? If you want to start naming digits, and the thumb is the first digit, and then there's going to be 2, 3, 4, 5, 6. So you could say there is a fracture of the terminal, the tip of the terminal tuft of the first digit, something like that if you want to. Okay, so let's go on to the next case. So this was the foot, and this person has come in with foot pain. So generally speaking, people who have kept up with me from the beginning of doing these webinars, I always trace around all the bones, right? That's the first thing. You just kind of trace around. But one of the first things I do, because after a while, there are very high yield areas when you're looking at fractures, especially of the foot, for example. So one of the high yield areas of the foot would be this area. Oh, it's all weird today. That area over there, that is a very, very high yield area for getting fractures. And so what you need to do is just make sure you've had a good look in that area. Hang on, let's change that. So you can make sure you've had a good look in the area around here. So base of fifth, very, very common. Label as thumb, index, middle ring. This removes any doubt. Yeah, I've seen that. I've seen both, actually. So someone is saying that they normally label it thumb, index, middle, ring, and little finger, and that does remove any doubt. I'm not saying either way is correct, and you are correct that will remove any doubt. But I have seen people say first, second, and third digit. I personally would actually go with saying index, middle, thumb, and ring finger. That's just the way I like to do things. But I've seen it done in other ways. Fine. So now when we're looking at this particular thing, so that's the first place you want to look. And then you want to just really trace along the actual shafts. That's like my next key area, really trace along the shafts. And again, you just want to zoom in and just make sure that you've had a really, really good look around. So if you've seen it, then let me know. If you haven't, don't worry. So we'll kind of go around like so. There's no osteochondral defect or anything there. This all looks okay. And actually this aligns quite nicely. So if that didn't align nicely, if that medial aspect of the second toe, second metatarsal doesn't line up with that intercuneiform articulation, then you're thinking, oh, there could be a Lisfranc injury. You want to make sure that things haven't kind of shifted across as well. So that would be another thing to think about. But as you kind of go along like this, you try and look to see if there's any sort of fuzziness, like anywhere along those areas, any sort of fuzziness anywhere. Fuzziness is like where you got a bit of a cloudy appearance. If you can't see any cloudy appearance, then fine, you're not looking at any sort of stress fracture. And generally speaking, you'd either get a stress fracture over in this region or in this region. Generally speaking, that's where I'm normally seeing them. You follow along like so, just make sure that you haven't seen a stress fracture at all. Of course, look at the rest of the metatarsals as well. The next place I would highly recommend you looking is to have a look at the metatarsal heads. Go metatarsal head, metatarsal head, because in those areas you get something called a Freiberg's infraction, which is basically like an avascular necrosis type thing going on here, can happen as a result of lots of marching. And then the other place you really want to look at, another high yield area, is again a bit like that thumb we saw earlier. Just have a look at that little toe, because people stub their toe, then get little fractures along there. Make sure you've had a good look at that nail bed. Make sure that's not Anything else is definitely not a fracture. That nail bed's going across like that. So any line along there you may think is a fracture. Have a look again. Terminal tufts, terminal tufts, terminal tufts. Has anyone seen anything so far? Go along like this? No, I haven't seen anything, not seen anything. So, you may be forgiven to think, okay, well, this is normal. There's nothing abnormal here. But actually, if we zoom in a bit to that second metatarsal, there is a kind of line going like this. Can you see this kind of line going across like so? I don't know if it's projecting very well, but on your own screens, have a look. But there is this very, very subtle line going across there. So that is actually a stress fracture. Very, very easy to miss when you're not looking. So very important that, yes, you do look for fuzziness, but have a look for anything else. And how do I know this is not a vascular channel? Vascular channels will go along like so, and they've got corticated edges, whereas this one goes completely perpendicular to the flow of the bone, as it were, a flow to the trabeculation, and it doesn't have corticated edges. So therefore, this is more likely to be a stress fracture. So this is a stress fracture of the second metatarsal. Right, let's have a look at this one. Again, open in review mode. So again, I'm going to go very systematically. Some of you may pick it up straight away, which is great. And obviously, if you do, put it in the chat so I know that you're here, you're awake, etc., etc. So whenever I look at chest x-rays, I just have a general look first. If nothing pops out at me straight away, then I've got check areas. My check area is going to be the cross-phrenic angles. That's over here and over here. And then you want to check the hilar as well to make sure that they're okay. Exactly. Well done. Some people are picking up. Like I said, some cases are easy, some cases are not so easy. Then you want to look behind the heart, make sure there's no abnormality behind the heart. Sometimes you have a bit of a hiatal hernia. You want to check underneath the hemidiaphragms as well, make sure that these are all nice and crisp, and there's no evidence of any air under the hemidiaphragms as well. And the next thing you want to do is check the lung apices. And the number of times I've seen apical pneumothorax is being missed. This is a slightly more obvious one, I guess, because you can see that, yep, people are saying it. There is a left-sided pneumothorax. How do you assess soft tissue swelling on the foot, especially around the metatarsophalangeal joint? I'm going to go back to that. I'll go back to that. Okay, so what we'll do is what we'll do is, one of the ways, if you're ever unsure, I think there's a slightly obvious case on this one, but what we can do is go to pan again, and you can see that you just literally draw a square in your mind, draw a square like here. Okay, and you can see lung trabecular, then draw a square over here. And genuinely, I used to do this, get a square with my hand, cover everything else up, put it there, then put it there and see what it looks like. And if there's a difference in the way that the opacification looks like, or you can see that there's not very much in the way of lung markings, you're probably looking at a pneumothorax. And the next part of looking for a pneumothorax is to look for that lung edge. And you can see that there is a lung edge going along like this. It doesn't conform to underlying bone structure at all, and you can definitely see that there is a crisp sort of stop of lung markings to no lung markings. And the reason why I say that's very important, because I've seen situations where you've got someone who's got skin fold, they've lost a lot of weight very, very quickly, they may have underlying malignancy or bariatric surgery, they've got big skin folds, and then in those situations people actually end up calling pneumothoraces when there are no pneumothoraces, and go and end up sticking like a drain in, which would be not great, would it? So I just want to, so hopefully everyone's seen that is a pneumothorax. So the next thing, being a radiologist, because all you guys are radiologists right now, even if you're not, is to make sure that you have a look at the bones, right? Very, very important, because if someone's got a pneumothorax, like, you have to think, okay, yes, pneumothoraces can be spontaneous, but the other thing is that you also want to make sure that the things that could result in pneumothorax are also ruled out. So in this particular situation, you want to make sure there's no rib fractures at all. So again, you just have a look at the rest of the ribs. You look at the posterior aspect of the ribs, and you follow it around all the way to the front. Someone's mentioned something which is really, really great, and exactly what I'm gonna use your little cue to do this. So this really works great for looking for rib fractures. Sometimes it helps just to look at it at a slightly different angle. So you can do that. And also that kind of sometimes helps just by reorientating your eyes to not only to have a look at the ribs, especially the edges. That can be very, very useful, because sometimes people do miss fractures right at the edges, and also can be a really good way to just follow that lung as well. So do make sure that you manipulate the images if you need to. And again, Collective Minds, like, it's an amazing thing that you can have like a fully fledged DICOM viewer sitting right here, where you can do the rotation, the windowing, the panning, and I'm also annotating with the software that I've got, because I do a lot of teaching, but you can actually actually do also get a pen like this and also like erase it with the word E on here as well. So it's a really, really useful platform. So someone is asking about how to tell whether there was soft tissue swelling on where was it? So how can you tell if there's too much soft on the metatarsophalangeal? I'm quite desperate to answer that. So I'm going to open that one. So it can be difficult. It depends on the age of a fracture. On the metatarsal, very, very difficult to see where there's a soft tissue swelling on the foot, because, you know, you're looking at the sort of soft tissue areas over. Okay, let's get the pen here. So you're looking at the soft tissue around here. So unless it's been very, very acute and very, very significant, you may not see very much in the much in the way of soft tissue swelling. You'd be looking for something quite extensive. When it comes to the actual toes, it can be a little bit more obvious because you may have like a really normal side and then it becomes really, really bulbous. I know that's quite an exaggeration, but it can happen. So I wouldn't rely on looking for soft tissue swelling. I mean, if you think you've seen a fracture, then you look for soft tissue swelling, then that can help. But otherwise, I wouldn't really rely on it. It can just be something that kind of alludes you to something. If you think you've seen soft tissue swelling, have a look at the underlying bones. If you can't see them, you may have to say soft tissue swelling, but no underlying injury. Pneumothorax case, is there a background of COPD? Okay, so COPD can be quite difficult to diagnose on chest x-rays. Obviously, there are some fiends out there that can, but the general rules I would say is to look for hyperinflation. People often count the ribs, but what I genuinely do is just have a look and see where there's any flattening of the underlying lung parenchyma. Is if there's any flattening whatsoever, then you're thinking to yourself, okay, there could be a hyperexpansion. Also, the lungs will be a bit more translucent because by definition, COPD, emphysema, would mean that there is less lung parenchyma. So the lungs, you know how here you can see lots and lots of nice lung parenchyma. In those situations, you wouldn't see so much. You may see there's a bit of a discrepancy, like there's lung parenchyma that looks a bit more black here compared to over here. It takes a lot of practice in truth, but that's the way that I would generally do it. Look for where they're hyperexpanded by doing this, and also having a look at the lung parenchyma, see if there's any sort of more translucent areas compared to others. Okay, another question that popped up here. Have I answered it? I think I've had you assess soft tissue. I've answered that. Okay, fine. So right, so let's go on to the next case. Okay, so hopefully this is a slightly straightforward one. Open link in your tab. Okay, so chest x-ray. Okay, so we're having a look at this chest x-ray. Again, my check areas. My check areas would be the hilar areas. So hilar actually look okay. They look very, very sharp. So that's good. Okay, good. So people have some good answers. I want you to think a bit further though. You give me one answer. There's two answers here. So think about that. Okay, so then let's have a look at the this is the aortic knuckle. That's over here. That looks okay. Lung apices. Remember before, we want to make sure there's no subtle pneumothorax. The way to do it is to draw that little square there, So let's draw a square. Make sure that we haven't seen any abnormalities anywhere. So yeah, someone's got it. Well done. So then put a little square there. Put a little square there as well. So yeah, it doesn't look like there's much in the way of a pneumothorax, but maybe slight asymmetry in the way those lung look, you know, because if you look here, there's a little bit of a circle there, which is not there at all. So let's zoom in and just have a quick look and see what's going on there. It doesn't look quite right there. Let's have a look. Yeah, so actually, when you look at the difference between that piece of lung there and then that bit along there, looks like a bit of a circle there. Maybe a circle there, bit of a circle there as well. Okay, fine. So now we've got something going on. Doesn't look quite right. So then you think, okay, so what could those circles be? Are there more? Yeah, so there's a circle there, another circle there, another circle there. Okay, what density? Is it bone density? If I'm not sure, I'll have a look at the bones. I know bones look like this, so it doesn't look like bone. It doesn't look like air, because air looks like this. Air looks like this on the outside of the body, but it does look like soft tissue. So that'd be soft tissue. That'd be soft tissue over here. So this looks like a soft tissue density. So what would look like, we've got multiple soft tissue densities scattered throughout both lungs. Okay, so that's one abnormality. And people have quite rightly said that it looks like there's air under the hemidiaphragms. So when you look around here, you can see that this is one diaphragm over here, and this is one diaphragm over here. You can get air within this region, or what looks like air within that region, because you've got the fundus of the stomach, and that lies within the underneath the left hemidiaphragm, unless you're looking at something like situs inversus, which is a whole other story. But you shouldn't have air on both sides. But here you can see a nice interface, not nice for the patient, but nice for us to see, that there is the liver and there's an interface here. Can you see that? There's a translucency over here, and that should not be there. Should not be there at all. So that's air under the hemidiaphragms. some of you may have also noticed that that bowel looks a little bit like it might be a bit abnormal. Can you see how it looks like it's kind of pushing upwards? Yes, you can see some haustra, but you've got to be worried that, first of all, you've got multiple metastases, you've got air under the hemidiaphragms and what looks like potentially dilated small bowel. In that situation, you wouldn't be untoward to say, this might be an underlying colonic carcinoma that may perforate and result in air under the hemidiaphragms, and this patient's quite far staged because they've got multiple metastases. Multiple lung metastases. Whatever the case, this person is going to have to need an emergency CT abdomen pelvis. If they haven't been imaged before, they're going to need to get a CT chest as well with IV contrast, if the kidneys can take it, to do a full staging scan. Right, so that was hopefully like a three-step process. Some of you got it all, some of you got some of it, which is fine. I think some of you are doing really, really well. Right, so let's have a look. So as you can see, the plain X-rays load up really, really quick with this platform. And genuinely, I use this for all my courses. And so if you guys do want to use it, do use it. What's really good about this as well is that you get to be part of the community. So there is, when you log into Collector Minds, there is like an online community where the people just put in loads of cases and discuss things and link things to stuff, which has been really useful for me. Because even though I am a consultant, I still feel like I'm learning, and I learn from you guys in these sessions as well. Right, so let's have a look here. What do we think is going on? So yeah, great. Some people have picked it up. Don't worry, I promise they will get harder. So we're having a look here. So first off, what I always do is, if it's not immediately obvious, I look at that flow of bone. You know how I said about flow of bone, right? So flow of bone is what I mean by this trabecular pattern. Have a look at that trabecular pattern and make sure that they're all flowing nicely. Also look at the edges here and make sure they all look nice and they're also kind of flowing around. Sorry, you're going all the way around like so. And actually everything looks okay on this particular side. So let's just reset the image and have a look at the other side. So let's have a look. And yeah, people have picked it up. So what I'm going to do, I'm going to zoom in. And do you remember I was talking about the flow of bone, right? On this particular side, you don't have flow of bone, right? It kind of looks like it stops there, stops there, stops there, stops, and you got this sort of radiolucent discrepancy going over here. So that doesn't look quite right. And it kind of all looks a bit kind of more dense and sclerotic within these regions. And you've also got this sort of linear line over here, and then it doesn't continue like the other side did. And you've also got that kind of discrepancy there. So this is clearly an impacted neck of femur fracture. So now when you zoom in, the next thing I would like to do, or encourage you guys to do, is just to make sure that you keep looking. So often I see inferior pubic rami fractures, superior pubic rami fractures, pubic symphysis fractures being missed because people have got so fixated on the fracture there. And also, sorry, I zoomed in and out there. But the final thing I'd also really highly encourage you guys to do is to have a look at this area over here. And just make sure that this is all kind of very, very smooth all the way along, right? Because sometimes when someone has such an impacted fracture, if they've got dodgy bones, it can actually fracture the acetabulum. What do I think about the contour of the inferior iliac spine on the left? Okay, so inferior iliac spine on the left. So let's just reset things. So inferior, okay, iliac spine. Are you talking about this area over here? Down here? Is that what you're saying? And this is about the inferior pubic ramus. Okay, you're talking about here. Okay, let's have a look. Let's have a look. So someone's asking about the inferior iliac spine on the left. So you may be thinking about, is there an avulsion fracture or anything like that? So this person, what I think is going on, what you can do is draw a line. I don't see an avulsion, because if it was an avulsion, if there was like a pulling off a bone, you actually have to have a pulling off a bone, because if a tendon pulls off the bone in a rested state, a muscle is contracted in the rested state. So if the rectus femoris, which is what attaches here, is going to be having pulled off there, then what will happen is that you'll end up having a fleck of bone over there. So that's one thing that I would say. I wouldn't say that there is I wouldn't bet on there being a what do you call it, a avulsion. Now you're saying there is an asymmetry. Yes, there may be an asymmetry. Yeah, 100%. So yeah, you could say that I think there could be a fracture. Very unusual to get a fracture of this, just the lip of the acetabulum. It's more common to have more increased osteoarthritis on one side more than the other. So you can actually get sort of superior lateral margin osteophytosis. Very, very common. You get labral tears as well. So you've got the sort of cartilaginous or kind of jelly-like stuff over here. You can get tears in the superlateral aspect of the labrum as well. So I wouldn't bank on that being like an acute injury. One thing I would say though, for the more subtle eyes, you can see that there is a line over here, which is kind of the joint capsule. But on this side, can you see how it kind of looks a little bit more bowed out like a little bit more kind of bulbous around that area. So that could tell you that, yeah, there is a fracture, and there's also a bit of a joint effusion as a result of the fracture as well. So yeah, it's very good to look for symmetry, but sometimes you've got to go with what's common, right? Okay, so it's very unusual to have a fracture within this area. It's very common to have osteoarthritis in the area. So if anything, I would say, I would suspect there's osteoarthritis located within the superlateral margin of that hip. But that's just based on my experience and what I've seen over the years. Okay, so let's have a look at the next case. So this is an abdominal film. And this is like a two-part case. So first off, can anyone just tell me what they think is going on? Like, tell me what you think is happening while I try and see if I can get my pen working again. Okay, yeah, so short, yeah, exactly. So someone's written SBO. I think we can all agree that there is something up with that bowel, don't we? I think we can all agree there's something very, very abnormal about that bowel. Perfectly correct, completely correct. But anything else about this particular bowel that doesn't look quite right? Anything else? Yeah, excellent. So some people have said it. Okay, so what we'll do, we'll start explaining it now. So first off, we're looking at an abdominal film, and we can see that there is this quite what looks like multiple loops of dilated bowel, right? These are bowel, all sitting within the central abdomen. So that's the clue. The other clue is to see what the haustra, whether they've got haustra, whether they've got valvular conniventes. And that basically means that there's basically, hang on, we'll just reset this image, reset all. So valvular conniventes are lines that go all the way across. In haustra, they go only part of the way across. So if it goes all the way across, you're looking at small bowel. If they go halfway, that's going to be large bowel. So this is actually going to be small bowel. That's what we're looking at. So on top of that, what we can see is this radiopaque density sitting within the central abdomen over here. And you can also see there's kind of got layers. Those are layers, right? That doesn't look quite right. So someone has said this could be gallstone ileus. And the other thing to look for is whether there's any air within the biliary tree. So the liver is sitting up all the way over here. You can see a bit of air anyway, but it almost feels like there may be some air, kind of more linear fashion, sitting within this area over here. And that therefore must be air within the biliary tree, because what's happened is that this patient has had a gallstone that's come out from the gallbladder and gone all the way down the small bowel and then ended up getting lodged up here. Now, the reason why I thought this is quite a nice case is because I do have the follow-up, which I think is case number 13. So I'm going to open that one up for us, just so we can actually have a bit of completion of the case. And the good thing, what I'd encourage everyone to do is click on here, and it will start to download down, and see that red line going all the way across. You see how quick that is. It's going to come along, and eventually once that red line has come across, we'll be able to see what things look like. And so as that comes across, we can start from the very, very top. So straight away from the very top, we can see that first off, this is a contrast enhanced study. There's contrast within there. And can you see the esophagus is sitting right over here, right? So now as you kind of go down, we can see the esophagus looks a bit fluid filled, okay? Stomach looks a little bit distended. That doesn't look quite right. The whole stomach, the pylorus looks distended. It all looks very, very distended, all the duodenum. And then going across to this area, this all looks distended as well. That looks distended. So it looks like a lot of the proximal bowel all the way to the stomach is very, very distended. And so much obstruction is going on that there's fluid located within the esophagus. So that doesn't look quite right. So let's confirm or refute what we thought. From the x-ray, we can see, yeah, exactly like we saw in the x-ray, there is air within the biliary tree. You can see that. We know it's not on the portal vein because the portal vein is sitting over here. Also, the air doesn't go all the way to the edges. So if it went to the edges, then it would be worried that there's a portovenous gas. If it kind of goes within, not all the way to the edge, and that's probably going to be looking at biliary air. And then you can see that the biliary air goes all the way along into here. Now let's find the gallbladder. Gallbladder looks like it's sitting over here. We're trying to look for any sort of communication between the gallbladder and the bowel. I feel like it's all the way over here. So there is a communication. So now let's have a look for the actual gallstone. There you go. Can you see it? Right bang over here is a massive gallstone. And it's exactly what gallstones look like on CT. If anyone hasn't seen it before, gallstones look very, very lamellated. So like layers, lots of layers when it comes to gallstones. And when they slip through into the bowel like that, it can result in this sort of gallstone ileus, this sort of obstruction looking appearance, okay? And the other thing you can try and do is follow the bowel. So you can see the bowel coming out this way, looks quite collapsed, all right? But then if we go the other way, the other way, you can see from that point upwards, it's very, very dilated. So that's another way to look for transition points, a transition point from normal bowel to abnormal bowel. And even if there wasn't a gallstone, if there was like a transition point there, you'd have to say in your report, there is a transition point located within the left lower abdomen. And if you can't see a gallstone, whatever, you may have to say, not entirely sure what that is. It could be, previous surgery, like yeah, you can have previous surgery that can cause that kind of thing. And stuff like that. Right. So we've been through case number 6. So let's have a look at case number 7. So this looks like it is a lateral view. Can you repeat, if the air went all the way to the liver edge, what should you think of? Okay, so if the air goes all the way, so that previous case, if the air goes all the way to the edge, so I just want to go back, that's a really, really important thing. So if you learn nothing from me today, apart from this, yeah, this is going to save lives. So, and hopefully by extension, I've saved lives too, which is kind of fun. Right. So if the air goes all the way to the edges, right, it must mean that the air is located within the venous system. And if it's located within the venous system, it must be coming from somewhere. So where would it be coming from? So air within the venous system would be coming from the portal vein. And if you follow that portal vein, eventually you will split into like multiple kind of tributaries and eventually go to the bowel. So if you've got air that is going along these tributaries and then essentially going all the way to the bowel, that must mean there's air being produced within the bowel that is now going up into the vessels. The only real situation, or the worrying situation, where air would go into the bowel is if the bowel is dying. So if the bowel is dying, then you end up getting air within the bowel wall. Not, you know how here you've got air within the bowel. If you've got air within the bowel wall, that must mean that there's necrosis of the bowel wall. The bacteria start eating. The air starts to travel into the venous system. It goes all the way up into the portal venous system, all the way into the actual portal vein. And then it starts to sort of settle within these areas. And because when you come to the portal vein, like blood has been pumped all the way to the edges. So now instead of having blood pumped all the way to the edges, you're having air pumped all the way to the edges. And so that's why air would go all the way to the edges if it's portovenous gas, and that's worrying. But with the biliary system, the bile is going outwards, right? It's going outwards and through because you're trying to push bile out of your liver. So therefore, it's not going to the edges, it's going away from the edges and into the rest of their system. So that's really important. So very, very important to know that there is a big, big difference and real clinical implications for calling biliary air versus biliary air versus portovenous air. Right. So let's have a look at this one. We can hopefully get through this one fairly quickly. So this is a lateral view of the wrist, and we're kind of going along like so. And first off, what I try and do is make sure that I'm kind of drawn around whichever bone I think is which. So you can see that this is probably the ulnar because it's kind of got that Smurf hat at the top of it. And the more flat one is going to be that radius, right? So then if that's the radius, therefore you got to really look closely. And I don't know why, let's go to, not rotate, let's reset all. And so you can see that there is, I never heard that phrase before, locotypical fracture. I'm going to look that up. I never described that as a locotypical fracture. It's maybe a phrase that I've never used before. But you can see there's like a little discrepancy there. And you can go along like so, and then you can feel like there's a discrepancy there as well. And then you go along like this. As a radial head. So radial head is all the way the other end. So this is the distal radius. Radial head is at the elbow, but distal radius is over here. So it's quite important that you when you do these, that you you say that the distal radius, that's the radial styloid. And radial head is right at the end where it ends up with the radiocapital attachment. So this wouldn't be radial head. This would be the distal radius. And you can see that there is a radial lucida that goes all the way to the edge like this, all the way down that way, and all the way down that way. So therefore, this is a distal radial fracture. There's no angulation on this one. And there's articular surface involvement as well. So very, very important that those are the things that we say when you see a case like this. Occasionally, you will see soft tissue swelling. I wouldn't bank on it. I've seen people describe it. I wouldn't bank everything on that. Very, very important you have a look and see whether there's any sort of other fractures anywhere else on the bones or within the metatarsals as well, because those things get missed as well. Right. Okay. So doing very, very good. Let's have a look at this one. I've actually got a really great explanation for what this is saved up for you guys. So again, let's have a look at this X-ray. Hopefully something jumps at you. If it doesn't, don't worry, I'm going to go through it. So let's have a look. So cost-phonetic angles, yeah, that looks kind of quite sharp. I don't think I can see any sort of blunting. Let's see the next cost-phonetic angle. A bit difficult to see, but I don't think I can see any sort of any blunting there. Behind the heart, nothing there. Behind the hilar, I mean, the hilar regions look okay. Look at the lung apices. Lung apices look okay, and look at the lung, and then yeah, you can see that there what looks like a big opacity located within that region over there. Now you think, okay, what is that opacity? What you need to do is really zoom in and just have a look. And can you see that there are these sort of radiolucent lines going along like so, going along like so, going along like so, going along like so, right? So those lines are basically air bronchograms, right? And air bronchograms are very, very important when you're trying to identify consolidation. Now, consolidation can happen for lots of reasons. It could be infection like pus, it could be lymph, and it could also be blood. So depending on the clinical history, you can have consolidation. So it's always a good idea just to have a look and see whether there's any fractures anywhere. If there are no fractures, great. You may be looking at infection. Also, you have a look at the clinical history. If it says they've got underlying infection, then fair enough. So the way I like to describe it, so why have this person got this kind of extensive radiopacity with these linear radiolucencies going through it? And that's because of air bronchograms. But you may throw air bronchograms out there and think, what on earth does an air bronchogram really mean? So I'm going to draw on here first off. So when you're looking at the air, they look like little kind of nets. They look like a net, right? And then within that net, there's like little dots. And they're like that because actually they're like little cylindrical bottles. Like let's say they look like bottles, right? And those little dots actually correspond to tubes, and those tubes are the bronchograms. And the way I like to explain it is, if anyone would like to buy this for me, then that'd be lovely, is try and look at this bottle. So some of you may have seen these bottles when you go to Amazon. My kids have got these ones. They kind of got a plastic layer. Then they got always glitter. Then they've got another plastic layer. Then you've got where you've got your drink. And then you've got a straw within the middle. So you may notice that when you fill this up with water, the straw doesn't get full with water. That stays completely full of air. And that's exactly what happens. So imagine that was like the lung. The straw is the bronchus, the bronchogram or the bronchiole. And so when it gets all full of pus and full of fluid, the straw doesn't get full, and neither does the air bronchogram, the actual bronchiole. And that's why you get these radiolucencies, exactly like that. So just imagine that like tiny little bottles, and the little straw doesn't get full of fluid. Everything around it gets full of fluid. And then, yeah, I mean, that's just a good way that I used to try and explain it to my registrars. But anyway, that's consolidation located within the right upper lung zone. That's how I would describe it. Right upper lung zone. Sorry, and one more thing with that particular case is you don't just stop at the right upper lung zone, because infection can cause it, but also malignancy, squamous cell carcinomas, there's loads of malignancies that can cause these things. Just have a look at the hilar, make sure there's no lymphadenopathy, make sure the mediastinum look okay, no lymphadenopathy, and just make sure there's nothing else going on, like a destructive bone lesion or anything like that to suggest that there is an underlying malignancy or anything more sinister going on. Right, let's go to case number 9. So case number 9, hopefully is not too bad, but what we'll do, you try and make sure with every single shoulder that there is some overlap of that humeral head with that glenoid. If there's no overlap, then you've got to start worrying there could be some sort of dislocation, because everything with the shoulder acts like it's in a balance. But that shoulder looks okay. Then greater tuberosity is a very, very common place to get fractures. Seen that happen quite a lot, because I assume what's happening is when someone has a significant impact, there's an impaction between here and the lateral acromion, and you get a bit of a greater tuberosity fracture. Or maybe it's just because if someone does get directly hit, it's usually going to be in that particular area over there. So that all looks okay, and the shaft looks okay. And what I actually do, in truth, I have a good look at the ribs, because if someone's had a significant injury, yeah, they may have had a rib fracture, and that's one thing you want to look for. Make sure there's no rib fractures, which they're not. Have a look at that scapula as well. You can see the scapula going all the way around like so. Please do not confuse the edge of the scapula for a pneumothorax. Always follow it around, all the way around like so. And you can see the lung markings going all the way to the edges. So it can't be a pneumothorax, right? And then you look at the clavicle. Medial edge of the clavicle can be a bit difficult to see, but as you go along, yeah, exactly right. Someone said it. There is this what looks like a discrepancy over here. Can you see that? Like a lateral clavicle fracture. And what looks like there is probably a fair bit of soft tissue swelling over here as well. So quite a significant fracture over here on that sort of lateral third. And very, very common to get fractured lateral third. Less common to have fractures in the middle third, actually. If you need a significant force for a kind of medial third of the clavicle to get fractured. Right, let's have a look at this one. Now, C-spines can be really, really worrying. Generally speaking, these days, I've noticed that people tend not to get... I mean, generally speaking, when someone comes in with significant trauma these days, you just end up getting a CT, don't you? But I think maybe C-spines may be a bit of a dying art, because if someone is, worried, you just end up getting, you just get a CT scan. For some reason, that's not loading up just yet. Don't worry, we'll just go to the next case for now. I wonder if my kids are on the internet. That could be what's going on. Just come home and watch Netflix. Okay, so not sure what's going on. What I'm going to do is I am going to just re-upload everything. Yeah.
I think it's something with your internet.
Yeah, it must be. It must be. It's fine. This happened to me once or twice during courses and stuff. So I just reload the page and stuff, and it should be all right. There you go. See, just reload the page. It's fine. Okay, so let's have a look. So the way to do this is to have a real good look, and you zoom in. And one thing you do, someone's on fire today. Okay, so you kind of go along like this and make sure that everything's nicely in line. So that's good. Nothing looks like it's out of place. You want to see if there's any soft tissue swelling. So it should be very, very thin around this area, and about 1, 2, 3, 4 around the area should start getting a bit thicker. That's kind of fairly normal. I always look at the facet joints and make sure they're all nicely aligned. That's another thing to make sure. We've also got to make sure we can see, like, how many vertebrae can we see? So we can see like 1, 2, 3, 4, 5. Can't see 6 or 7. Yeah, that's not great. So there could be, I've literally seen situations where the fractures down here, significant fractures, but that looks okay. Have a look at that spinous process, because sometimes you get, I literally, actually the other day, someone was doing squats in the gym, and they put the bar on there, and it must have been so heavy. I don't know what must have happened, but they must have been so heavy they actually literally fractured the spinous. I've never seen an injury like that. And maybe a reason why you shouldn't go to the gym. I'm just joking. You should all go to the gym. All right. So let's zoom in and have a look. And someone spotted it. Yeah, there is something very, very abnormal about that C2 vertebra. So if you kind of follow along like so, there is this abnormal radiolucent line. You can see that it's just going along like so, and that's so unusual. But the thing is, what's even more unusual about this is that when someone's got a fracture like that, generally speaking, you have a lot of soft tissue swelling. So that's a soft tissue, but this doesn't look like there's much swelling. So you wonder whether they've had a fracture for a while, and it looks so kind of a bit radiolucent, a bit jaggedy edged, and you know what I mean? Like, it doesn't look, if that was like, right, bam, done right there and then, you'd be expecting a lot of soft tissue swelling. But in this situation, you don't see much in the way of soft tissue swelling. In fact, you just see what looks like a discrepancy there. So yeah, that's exactly what it was. It was a C2 fracture. And I think, for completion's sake, I might have, yes, I do. So if we go to case number 14, this is the subsequent CT scan that happened off the back of that particular thing. So again, what I'd encourage you to do, if possible, is to download the cases. Shouldn't take too long, as you can see. And if you guys don't know, just like I was saying earlier, the really good thing about this platform, and why I use it so often for my course and stuff, is that you get a full like DICOM experience. And so you can actually do like a proper like sagittal view, you see, and it works completely fine, like just as you would expect. And so yes, there is a bit of artifact. For those that don't know, you do get a bit of this sort of wavy line sometimes, and that can be based on the fact that the person may have fillings. If they've got fillings, like tooth fillings, like metal, then when the x-rays come through, they end up kind of dissipating, and you end up having this sort of wavy look appearance here. But even despite that, we can definitely see that there is this what looks like a fracture there. Can you see that? It just doesn't look like a brand new fracture. It looks a little bit corticated on the edges, but clearly abnormal. In that situation, just got to make sure there's no other fractures anywhere else, and everything else looks okay. That distance between the C1 and C2 is actually preserved. We're not worried about sort of a ligamentous injury in that area either. So this looks like, straight up C2 fracture. probably a little bit more chronic than one would normally anticipate these fractures coming in. Next thing to do, just make sure these lung apices are okay, because on the odd occasion, I have noticed that there has been missed lesions in the apices when someone's been so fixated on the C-spine. And the other thing is also to look at the mandible, because sometimes these patients had significant injuries. They may be in a fight. You can get mandibular fractures. So just whatever bit of mandible that you've got, just make sure you've had a good look and make sure that you've seen there's no fractures. And just they do have a bit of osteoarthritis in that mandible there, don't they? Right, so we've done the C-spine. We're doing very well for time today. So let's have a look at this case. This is someone's foot. Right, so let's have a look. So what did I say to do? So always try and have a look at the shafts of the bone. Just make sure they look very, very smooth all the way along, all the way along, all the way along, all the way along. It looks smooth, doesn't it? It doesn't look like there's much going on so far. Okay, and then you want to look at the base of fifth. Base of fifth, I can't see anything immediately going on. Maybe, yeah, there's something there, isn't it? So if you zoom in a bit, maybe it's not projecting so well. Just wonder whether there's something going on, because that doesn't look quite right. That kind of fluffiness over there. So we'll come back to that. Just make sure there's nothing else going on anywhere else. So let's have a look. Everything looks okay here. Everything looks okay here. These metatarsal heads look okay. Let's have a look at the terminal tufts. Let's have a look at the terminal tufts, because that could be another place that people miss fractures. Let's pan. Right, so if we zoom in there, let's have a look. Terminal tuft actually looks okay. Is that overlap of the bone? Yeah, I mean the nail, yeah, I would actually say so. Okay, so terminal tuft, people coming out of the answers. Good, good, good. Okay, so that doesn't look quite right, does it? That doesn't look quite right, does it, over there? Okay, let's have a look. So reset all. That doesn't look quite right. So that doesn't seem right to me. Can everyone see that? So if we zoom in. I'm glad some people are really, really on it today. That doesn't look quite right to me. Looks like there's a bit of a discrepancy there. Looks like there could be a fracture there within that neck. So that's very well done. So let's have a quick look. Keep looking through. Terminal tuft. So I think we're going to discount anything going on there. I think that's going to be the fracture there. Everything looks okay. Everything looks okay. Everything looks okay. And I think I'm going to discount that. I think that's just probably the way they are. I don't see a fracture there. And then you do want to zoom out a bit and then pan out, zoom out. Navicular cuneiform. Very difficult to assess here. So navicular cuneiform, but there's going to be a lot of overlap within this region, right? So navicular cuneiform over here. Okay, so navicular cuneiform. There's going to be a lot of overlap. I'd be very, very aware to call anything. It's slightly at an angle. You've got like medial, middle, and lateral cuneiforms over there. Then you've got your cuboid. When you come up to here, can you see that? Hopefully people can see. There actually is this hidden little guy sitting over here, pretending to be all good, but actually it's not all good, is it? There looks like there's a fracture over there, doesn't it? That doesn't look quite right. And you can sort of draw, you can almost draw the fibula going around like so. But you almost feel like there is also radiolucency over here as well. That doesn't look quite right, maybe. So you'd be worried that there could be like a bigger fracture. There's like definitely lateral malleolus fracture, without a doubt. There's probably, there may be like a bimalleolar fracture, so you do need to get dedicated imaging. And also think there is a fracture sitting within that neck over there as well. So you see how like what can happen is that you can get really focused on one fracture and forget about the rest. But that's why it's so important to like make sure you have a look at all the entire X-ray, the entire thing, all the way through to the end. Right. Let's have a look at, so I feel like we're running.
Okay. I think there was a couple of questions in the chat.
Questions, yeah. A community lateral, yeah. What is going, I've answered that one. I've answered, yeah, so you're right about that one. I've answered these. So with the calcano-navicular coalitions, I'd be very, very careful, especially if you don't have an on-fast view, you don't have a dedicated view of the thing, because you get so much overlap. You really need a good view of these things. And sometimes you need to confirm coalitions on CT. There's just no other way. There's just no other way to do it. Right, let's have a look at this one. Let's zoom in. So generally speaking, on this one, I feel like the bones are a bit osteopenic. That's one thing to take into consideration. Also, you can see there's a lot of sclerosis within these areas. It looks very, very regular. So I think there's probably a bit of tarsometatarsal osteoarthritis, probably a bit of osteoarthritis over here. So that's what the calcano-cuboid articulation. So a bit of arthritis. So probably looking at someone a little bit older. Let's have a look at the shafts of the bones. They look okay. They look okay. Navicular. Oh yeah, you're right. Yeah, someone said there is a accessory. Yeah, fine. There is a bit of what looks like an accessory. So you can see a bit of radiolucency here, and that's a navicular, and then a bit of extra bone there. So that's an accessory bone. That's normal for this patient. Going along like so, going along like so, going along like so. Nothing there, nothing there, nothing there, nothing there. Basolateral. Okay. Okay, I'll find that out. So then we go to the base. So we look at the terminal, I mean the heads of the metatarsals. They all look okay as well. Let's have a look. Let's zoom in. Okay, so not convinced. Maybe there's some doesn't look quite right there. Can you see that? Doesn't look quite right. Looks a bit sort of irregular, like jagged edged. That doesn't look quite right to me. So I would be worried about a possible fracture there. Let's have a look at the rest of the shafts. No fracture, no fracture, no fracture. Oh, actually, hang on. There is a fracture over here. Can you see that? Going on like so. Big fracture, articular surface involvement as well. So that's definitely a fracture over there. And the only other part that I was a little bit worried about is this area over here, where it just looks like there's a bit of a cortical edge and this radiolucence, that kind of jagged edge like there. Can you see that? So I reckon there are probably 2 fractures there. Basolateral, interesting. I never really spoke. So see, basolateral could get, so someone said proximal phalanx, basolateral, basolateral fracture. So that I feel, I don't know what everyone else thinks, but when you say basolateral, can get a little bit confusing. The reason why I say it's confusing is because one thing is that this is medial, right? Your big toes are medial. So if you're going to say base lateral, then I'd assume you're talking about there. It's just easier to say the medial aspect of the base of the proximal phalanx of the big toe, right? And then you're done. Erosion of the metatarsal fourth. Okay, so 1, 2, 3, 4. Yeah, be careful. When you zoom in, you can actually see that this is very like nicely rounded. You can sometimes have these little dips. You can have these little dips on either edge. So unless it's completely caved out, I'd be careful to call erosions. But I think the definites on this, especially in the context of trauma, is going to be the fractures that I talked about. How do you identify a fracture has intra-articular surface involvement? So how do you know whether it's got intra-articular surface involvement? You try, okay, so I'll illustrate on this one. So if I reset, or someone's asked, how do you know if it's got intra-articular surface involvement? What you do, you just look and see whether it goes to the articular surface. So this is the articular surface. You can see this goes all the way to the edge. And if you look around the back there, you can see a radiolucent line. That's all it is. If you've got like a late radiolucent line goes all the way to the edge, all the way to here, you've got to say articular surface involvement, because that's the articular surface articulation. So this is an intra-articular fracture or articular surface involvement. Okay, do we have time for one more? Do we have time for one more? I think we do. Should we do what? Okay, let's do one more. So let's have a look at this one. This is a chest x-ray of an adult patient. Hopefully it's going to load. There you go. So again, we just do what you always do. Have a look at the costophrenic angles. Yeah, they look okay. Let's have a look at the apices. That looks okay. All right, so adenopathy. Someone said adenopathy. So we've got a aortic knuckle sitting over here. And then you can see that aortic arch going down there. Look at the hilar. It maybe looks a little bit, well, I don't know. I think that actually looks okay. But yeah, I agree. There's something a bit abnormal about that area there. It can be a unilateral adenopathy. It can be. Of course, it can be. There's no doubt about it. But it's very, very well circumscribed. It's kind of looking like it's at the level of the hilum. At least it's going to be anterior. Pulmonary artery, it could be. Very unusual to get pulmonary artery aneurysms, which is what I assume you're trying to get to. In truth, I don't think I've really ever seen a pulmonary aneurysm like that. And pulmonary arteries generally don't look so bulbous like that as well. So I would be a bit refrained from saying that's definitely going to be a pulmonary artery. Because at the moment, what we can see is what looks like a soft tissue density, loss of the AP window. Yeah, that's the AP window over there. I don't really feel like it's coming out of there. It feels like it's kind of more lateral and quite far away from it. So what we can say 100% on this x-ray is there is an abnormal lesion located within the region of the left hilum. It's very well circumscribed. The rest of the lung's completely clear, and there's no osseous abnormalities and no air in the hilum diaphragms. Lung apices look clear, and we can't see anything behind the heart. So this person's headed to a CT, aren't they? Yeah, they have to, right? And thankfully, we've got a CT to try and have a look and see what's going on. So what I'm going to do is, while that's going there, I am going to just let that download. So first off, we can see that this is a This is a contrast enhanced CT scan. And if we work from the very, very top, we can see actually this looks very like a CTPA, doesn't it? Because there's so much contrast sitting within the pulmonary arteries. And so someone said, could this be a pulmonary artery abnormality? Yeah, well, actually, the pulmonary artery looks okay. They're very, very well opacified. But what you can actually see is a very well circumscribed lesion located within this area over here. Someone said, is this tracheal deviation? Not really. I think that, it can wave a bit, but it's not really pushed in any particular direction. What we do have is this lesion over here. Can everyone see that? The great thing about this is usually should be able to choose a window. So let's go for long windows. And again, you can see this lesion sitting over here. Can you see that? Very well circumscribed. Which lobe is it? So we're in the left upper lobe, because you can see that sort of oblique fissure there, and sitting above that oblique fissure is this lesion. If we go back to the soft tissue windows, abdomen, you can see the vessels go around it. You can see that it's not invading the windows. Yeah. So that must mean it's been there for quite a while. There are multiple calcifications located within it as well. Well done. And actually, there's also some low density areas. So see that subcutaneous fat over there? There's almost what looks like subcutaneous fat sitting within there. Multiple calcifications. Exactly right. Someone's hit it nail on the head. This is a pulmonary haematoma. So nothing to worry about. You don't need to go and chop it out. You don't need to do anything else. This is a pulmonary haematoma. They've had it for a very, very long time. So great. Thank you so much. I think that's pretty much you say atypical location. Fair enough. Like typical, atypical. The truth is you're not going to do anything about it. You're not going to do about it. It's a leave alone lesion. Nothing to do. Yeah, Master, thank you very much. You're always welcome. You're one of our regulars, I can see. Okay, so thank you very much. We've had a very active session today. I really do appreciate it. As always, I have to say thank you to Collective Minds for allowing this to be possible. And thank you to all of you guys for turning up and making it really, it's always fun. I learn from you guys as well. So it's always good fun. All right, so with that, I'm going to pass on to my colleague Seidel, who will ask for you guys to give a bit of feedback. And by the way, feedback is really good for me because it kind of tells me if I'm not doing great. I need to know because I like to teach. This is what I like to do. And if you are interested in coming to any of my courses, I do run courses for radiology seminars. So radiology seminars, we do some really great courses, and that's got really good feedback as well. So do come along if you are interested. Otherwise, we do this every month. You can learn from like this as well. All right. Bye, everyone. Have a good evening.
Yeah. Well, thank you so much, Imran, colleague. We're actually cousins, believe it or not. But I sent a evaluation form. Please fill that out so we can send out the CPD certificates for you. And if you would like to try out the AIs that, on our platform, you can do so in the global community, as I showed you at the beginning. Please, on the evaluation form, you can tell us if you want some other cases or if you want us to bring in someone else, maybe MRI brain consultant or something like that. So please keep us informed. And I wish you the best rest of your day. And I hope to see you on the next webinar. All right. Okay. Bye-bye. Thank you.